When someone receives a soft tissue sarcoma diagnosis, the confusion is usually very big at first, because who can really imagine what that means? Whereas, when one receives a diagnosis of breast cancer or colon cancer, it's something that can be imagined and one knows what happens next. That's why it's so important that today we have the opportunity to talk with Professor Casper about it. You are the medical director of the Mannheim Cancer Center and also the coordinator of the Sarcoma Center here in Mannheim. Thank you so much for your time. So, my first direct question: what exactly is a so-called soft tissue sarcoma?
Yes, a soft tissue sarcoma is ultimately a malignant soft tissue tumor that can essentially arise from all kinds of tissues. This can be connective tissue, supporting tissue, muscle or fat tissue, and thus, soft tissue sarcomas are clearly distinct from tumors, from carcinomas, which arise in organs or glands, such as in the lung, intestine, or mammary gland. The term sarcoma, in the end, even comes from Greek and means flesh. And so it actually describes what we refer to as supporting tissue or connective tissue. These are the places or cells where these soft tissue sarcomas develop.
My first question is, of course, is it actually cancer or is it not cancer?
Of course, it's a malignant tumor, but we'll get to that later. The term soft tissue tumor just describes a swelling, a mass, and doesn't say anything about whether it's benign or malignant. We need to find that out first. But the term soft tissue sarcoma is the malignant variant of this soft tissue tumor.
You already mentioned it a bit, but I still wanted to go into detail. That's why I brought a picture here where we can see all the possible structures of a human. The first thing we see here is the human skeleton. And I would have spontaneously said, well, there can't be a soft tissue tumor on that because the skeleton is hard.
Exactly.
Right?
We distinguish between sarcomas in general. There are bone sarcomas that can actually originate from the skeleton, that is, from bones. But here we are really only talking about soft tissue sarcomas, and they can actually only arise from the soft tissue, from the supporting tissue.
Next, we see the muscle man, where we can see lots of muscles and tendons. And could there actually be something coming from various structures there?
Exactly. That is often the muscles, but also fatty tissue and connective tissue. This is mainly in the extremities, especially the lower extremity, thigh, lower leg, but also upper extremities. But it is all what we refer to as soft tissue or supportive tissue.
So the lungs are sort of out of the picture. Sarcomas do not originate from the lungs?
Not primarily. The lungs play an important role, but more in the context of metastasis and not primarily in sarcomas.
And what about the blood vessels?
Blood vessels can do the same thing. So there are sarcomas that originate from vessels, from blood vessels. That is definitely also a possibility.
Okay, and now we have several more. So now we also have the nervous system.
There are also sarcomas from nerve tissue.
Really? How about the lymphatic vessels?
Well, the lymphatic pathways are actually not primarily the starting point for sarcomas. But as I said, they can basically originate from all these tissues.
Yes, but it is indeed surprising to see the extent to which they can come from so many different structures. So I think it was important to get a good overview at this point. Exactly. Thank you very much for that. Let's go into more detail now. It wasn't visible in the picture, but the topic of fat and fat in the body is also relevant, isn't it?
Fat tissue is one of the most common subtypes, the so-called liposarcomas, which originate from fat cells, are very often found in the abdominal cavity, simply because there are relatively many fat cells there. But they can also be found in the extremities, arm, leg.
Exactly. That brings us back to the question. You already hinted at this, but where do soft tissue sarcomas primarily occur?
As mentioned, they can generally occur in any connective tissue throughout the body. We have certain regions where we find them more frequently and less frequently. The most common location is actually the extremities, meaning the legs for the lower and the arms for the upper extremities. And then we find them in smaller percentages, but ultimately scattered throughout the entire body.
And I think that's really, and I'll put this in quotation marks, a problem, because I don't think many doctors would expect to find anything malignant in the legs and arms. They always look at the organs, but most of them don't think about the legs and arms.
Exactly. And the problem is also that the patient with a suspected sarcoma can end up at any doctor. That could be with an orthopedist or with a general surgeon. But if it is in the head-neck area, it could be with an ENT doctor or with an ophthalmologist. And that's also part of the difficulty, which ultimately has to do with the rarity of sarcomas. Many sarcoma patients initially present to doctors who may not be very familiar with the disease or who may only see a sarcoma once in their lifetime.
And I think the topic of rarity is a good segue into the next point. I did a little research and came across a really great paper. Then I looked again and realized that they had co-authored it with your colleagues here. And then you can really see how rare it actually is. Because even in old age, when the rate does increase, it's still only around 10% of other cancers.
Exactly, as I said, overall a rare disease? No question. We assume that soft tissue sarcomas account for only about 1% of all tumor diseases in adulthood.
So tumor, but now in the sense of malignant?
Of malignant tumor diseases, exactly. There is even a number that we have also established at the European level. A tumor disease, a malignant tumor disease, is called rare when the incidence, that is the occurrence, is less than 6 cases per 100,000 inhabitants per year.
So if I take 100,000 inhabitants who are actually healthy or have other diseases, I have no idea what. So not only cancer patients, but in general. And then out of those, less than 6.
Exactly, within 1 year.
Within 1 year. Okay. Yes, that is really few.
And then there is also the difficulty, because the term soft tissue sarcoma is not just one disease. It is actually a collection of very different diseases. Namely, depending on which tissue the sarcoma comes from, we distinguish many different subtypes. The World Health Organization, that is the classification, distinguishes up to 150 different subtypes. And that, of course, creates further diversification in the already rare disease.
And that is, of course, a very, very big challenge. And one point that stood out to me when I looked at this is that, in contrast, I also brought along the picture of lung cancer, where you can see how many more cases there are. But you can also see here that lung cancer really only starts, let's say, with the very first tiny cases, like at 35 to 39 years old. And before that, there's really just nothing. It's completely empty. And I think what is also noticeable here is that even in small children, there is a relatively high incidence, but also among adolescents, there is already a certain incidence present.
Exactly. We actually have a peak at a very young age. So in infants and really small children. As for adults, the peak incidence is clearly in older age groups, around 60 to 65. But as you correctly said, there are no zero cases, so younger patients, including children and adolescents, are also affected. However, these are often not just soft tissue sarcomas. In adolescents in particular, we very often find bone sarcomas.
Whereby this refers to soft tissue sarcomas.
Yes, this only refers to the soft tissue sarcomas
Is
here.
there any explanation as to why more men than women get this disease in old age?
Not really. The gender distribution is relatively equal. There is actually a slight surplus of men, but it's not that pronounced. What can also be mentioned is risk factors. Are there risk factors? Actually, there are not really any specific ones. Most arise, as we say, sporadically. There are, however, things like radiation, chemical substances that can actually induce a soft tissue sarcoma, or a sarcoma in general after years in some circumstances. And there are also sarcomas in rare cases that are hereditary, associated with so-called hereditary syndromes. But these are really rare cases.
But are they clearly known then?
They are clearly known.
Okay. That means if I had such a disease now, I would also have to worry about my children, so to speak.
Yes. Then there are options for counseling. Every center offers human genetic counseling, just like we do here. And then you can get advice there.
Now, this is also an issue, and I think that's why there is sometimes confusion, poor advice, or poor treatment of patients, because as you said at the beginning, there are many benign soft tissue tumors. What's the approximate ratio between benign and malignant?
As I said, the term soft tissue tumor is completely neutral. It can be benign or malignant. It is simply a swelling, a mass that we can see or perhaps cannot see because it is deep inside. The ratio and the problem is that benign tumors are far, far more common than malignant ones. That is the problem from my diagnostic point of view. One can roughly assume that for 100 masses, there is one sarcoma. And that's exactly the problem for the practicing surgeon, or generally in primary diagnostics. We have a lot more benign tumors than sarcomas. And fishing out the sarcoma, that's ultimately the art.
So I have brought a picture of a lipoma, which is a benign fat tumor, and I think almost all of us know someone who has it.
Exactly. They occur very frequently, and that is, as I said, that is simply the problem. The benign ones are much, much more common, and truly pinpointing the malignant sarcoma is actually the difficulty.
But if someone then says, "I've diagnosed you with a malignant tumor," the probability that they are wrong is very, very low, right? So is it even likely that a doctor who has really taken a close look at it would mix up or confuse a benign tumor with a malignant one?
Honestly, purely from the clinical picture, it is not necessarily possible.
Okay.
Both can grow, whether they are benign or malignant. We have certain indications that suggest something malignant. For example, very rapid growth or a swelling that does not cause pain. Or also, a swelling that is more deep-seated. Those are at least indications that suggest something more malignant. But in the end, I think we're already on to a next topic here. Without actually taking a tissue sample, I can't really make a definitive statement.
Now, you said that there are 150 different types of soft tissue sarcomas. I would like to take a look at the most well-known or most common ones with you. And I believe that one that is very, very common is the one that originates in fatty tissue?
Exactly. Liposarcomas from fatty tissue. They certainly account for 20 to 25% of this entire group and are among the most common types. They typically occur where there is a lot of fatty tissue, namely in the abdominal cavity, but also in the extremities, arms, and
now
legs.
I have to ask the really dumb question. Does someone who is heavier, meaning has more body fat, have a higher risk? Does it have anything to do with it?
It has nothing to do with that at all.
It has nothing to do with it. And then there is another kind that comes from the muscles.
Exactly. These are called leiomyosarcomas. This is the second most common type that occurs in the muscles. There are different types of muscles. These can be the muscles that are basically attached to our skeletal system, meaning those responsible for movement in the arms and legs. But it can also be smooth muscle located in organs and blood vessels, taking on muscular functions there. Both different subtypes can ultimately arise from these.
Obviously, it also happens quite frequently that undifferentiated, or as it is called, undifferentiated pleomorphic
Exactly,
sarcoma.
undifferentiated.
What exactly does that mean?
Exactly. This is the pot that we cannot assign to a specific cell type. So ultimately, what the pathologist does when he looks at the sample under the microscope is he checks, which cell type can I assign this tumor cell to? And then there remains a not small percentage, also about 20 to 25% of tumor cells, which we simply cannot assign to a specific cell type. And we call them undifferentiated pleomorphic sarcomas.
But at least we know that it is actually a sarcoma and somehow came from the connective tissue, right?
Exactly. It comes from this type of tissue. They typically occur in older people, that is, older adults, and from their location, can also be in the extremities.
And then there's a very special one. I also find the name very difficult. Synovial sarcoma.
Exactly. Synovial sarcomas are sarcomas that arise from the tissue around the joints, so to speak, and from the so-called synovia. That is a fluid, and that is the typical localization where this type of sarcoma arises. Frequently very, very difficult, because they naturally at
Several structures are attached.
Exactly, are located in structures that are simply difficult to approach, surgically and otherwise. By the way, it is also a subtype that we mainly find in young adults.
Okay, and which joints are usually affected?
It can be a knee joint. It can be any joints, shoulder joint. These are indeed typical locations.
And then we have another one, and it actually doesn't really belong in this group here. I must openly admit, I'm also a bit struggling with that. Where do I categorize it now? That's the so-called GIST. What does GIST even stand for?
Exactly. GIST stands for gastrointestinal stromal tumors. They are also categorized in this group of soft tissue sarcomas, which isn't entirely accurate in terms of their origin. They do not originate from this supporting tissue like all the others, but they come from the so-called interstitial cells. These are the cells in the digestive tract that are essentially responsible for coordinating intestinal movements. And GIST arises from these cells. It's a somewhat specifically described type. Frequency peak, between 50 and 70 years, so also more in the older adulthood, but it's also not a rare type. It accounts for 20% of all soft tissue tumors, malignant soft tissue tumors.
And that is definitely not colon cancer. So colon cancer is something completely different from this.
Right.
Okay.
They develop from completely different cells in the intestinal wall, so to speak.
Okay. And as we already said, there are lots of others, but maybe we'll talk about the very, very, very rare varieties sometime soon. And now we come to the main question, which we briefly touched on at the beginning of the conversation. What are the symptoms that patients should look out for? But you already mentioned that there are many doctors who are involved in this area and who should perhaps sound the alarm bells. Could this be a soft tissue sarcoma?
So typically, a soft tissue sarcoma is noticed because of a swelling. It's a mass of any kind, and it can look like a lipoma. At first, we don't really know what it is actually. The problem, as mentioned, is classifying them as benign or malignant. We know that there are actually many more benign of these masses, and ultimately, we need to figure out whether it's a sarcoma or not. There are a few indications, as I have already hinted, that suggest something more malignant, such as very rapid growth. For example, the malignant variants often don't cause any pain. We have swelling, but it doesn't hurt. We also often have swelling that is deeper down. You might not even be able to see it from the outside, but you can feel it. And ultimately, you just have to take the next step. Otherwise, you won't get anywhere. Yes, the next step. The first step is imaging. So I just need to get a picture of what I'm seeing, and there's a clear standard, which is actually magnetic resonance imaging.
But to be honest, that's where I always think, until you even get there. And also what you just said, that often the swelling isn't even visible from the outside. Often, tumors grow to an astonishing size inside the body rather than out of it. And I always wonder because we all know how long it takes to finally get an appointment for an MRI. It's all water under the bridge until you finally get an MRI appointment. Isn't there some kind of simple, easy ultrasound? Can you see that on an ultrasound or not?
Yes, of course there are quicker and cheaper ways, but ultrasound can only provide certain indications. For example, let's consider a soft tissue sarcoma in the abdomen. This can, as you have also hinted a little, actually grow into a relatively large tumor without any discomfort, without anyone or the patient even noticing it at all. So yes, ultrasound can have an indicative character, but it never replaces adequate cross-sectional imaging, and that is actually magnetic resonance imaging.
So my point is simply this. I believe that for patients, it is often, and I truly speak from personal experience, very difficult to find a doctor who will refer you and then actually get an appointment. And if you could already see it on the ultrasound, the motivation to send you to the next step would be significantly higher than just saying, I feel so strange.
But it is important that it definitely should not stop with the ultrasound.
No, that's clear. That's
I
clear.
really need a proper diagnosis.
Yes, exactly. Magnetic resonance imaging is definitely clear. Are there cases where you would rather do a CT scan?
So actually, one can assess soft tissue tumors better with magnetic resonance imaging. So that is indeed the gold standard.
Okay, so that means the doctor who says, that needs a closer look, should definitely send an MRI image. And when you have this imaging, and it shows that there is a mass, as they always say, or in short, a tumor, how do you proceed from there?
I mean, if there is a suspicion that there is a tumor, the next step is obtaining histology, what we call a biopsy, a tissue sample extraction. We use a fine needle to extract a small piece of tissue from this tumor and send it to the pathologist, who has the task of making the diagnosis.
And I believe that we have now definitely reached the point where the clear message is, if there is a suspicion of sarcoma, then you should go to a sarcoma center. So my question to you would be, in this process, in this story, where do you think is the point where we really have to say very clearly to both the referring physician and the patient, okay, that's it. Now please go to a sarcoma center. When should that happen, roughly?
It should actually happen as early as possible. In principle, we even recommend doing it before the biopsy if possible, because the way the biopsy is performed, the access that is made for the biopsy, can be very important for the upcoming surgery. Because if I then have to perform the surgery, I have to remove the channel through which the biopsy is performed. And if this has been done poorly, I may have to perform a much larger operation than would otherwise be necessary. So that's just an example. We strongly recommend sending patients to the centers as early as possible. Ideally before the biopsy. If there is a suspicion in the imaging of a sarcoma, then it's really the first step. As I said, the recommendation is simply due to the rarity. Many colleagues, who just don't see such a tumor that often, simply don't have the experience, the expertise. That's not a reproach at all. It's simply like that. It's just due to the rarity. But that's why we have the certified centers, and it is certainly advantageous to send patients there, where there is simply more experience and expertise. The same goes for pathologists, by the way. Particularly in those cases, it is sometimes not only difficult to make the diagnosis itself, but also to diagnose the correct subtype, which can be crucial for selecting the right therapy.
So here we are in Mannheim at a sarcoma center. How do I find sarcoma centers?
So there has been a system in Germany for 5 years, organized by the German Cancer Society, a certification system, and there are certified sarcoma centers. You can get information there.
So I just Google Certified Sarcoma Center.
There is something called an OncoMap, which lists all centers, not only those for sarcomas, but also for colon cancer, lung cancer, and so on, for the most common ones. And there I can see exactly where the sarcoma centers are in Germany. At the moment, we have around 20 certified centers, actually relatively evenly distributed across Germany, and that's relatively easy to find out.
And then, once I've found one, I can also get an appointment here? Or do I have to wait again?
Yes, for sure. As a certified sarcoma center, we are actually obliged to see new patients within 5 days. This may not always work out in practice, but of course we strive to give new patients an appointment very quickly and promptly.
That sounds great. And now we had talked a little bit before that sarcomas are overall not unlike cancers. So what are the typical therapy steps? What do you typically do?
The typical therapy steps are, of course, things we also do with carcinomas. It is essentially a combination of surgery, chemotherapy, and radiation therapy. We always talk about the so-called multimodal therapy. A sarcoma is rarely only operated on, only treated with chemotherapy, or only irradiated. It is usually a combination of the different modalities, and we discuss that. There are tumor boards, tumor conferences, where representatives from the different disciplines sit together and try to determine the optimal therapy.
And that's why it's so important that people really have this specialization. so that not only one doctor has knowledge about sarcomas, but the other colleagues do as well.
And there are just the different building blocks. Of course, the core of sarcoma therapy is always the surgery. I definitely want to remove the tumor as radically and completely as possible. And it also plays a very crucial role in the patient's prognosis. I have other treatments that can complement each other. For example, I can perform chemotherapy before or after the surgery, pre or post-operatively. The essential importance of chemotherapy is, of course, more in the advanced metastatic situation. The same applies to radiation therapy. It is mainly used as a support to surgery, that is, either before or after the operation, and it essentially aims to reduce the recurrence of the sarcoma after it has been removed.
And are things like immunotherapy already being used?
Immunotherapy, unfortunately, does not play as much of a role in soft tissue sarcomas as it does in many other tumor entities. There are actually very few subtypes that we know of where immunotherapy is effective.
So that's exactly the point. It doesn't matter because it doesn't work.
Exactly. For most subtypes, it doesn't seem to work, but there are certain subtypes where immunotherapy actually plays a role. But those are really niches. And then we also have the topic of clinical studies. Sure, clinical studies are always an option when I have actually exhausted the approved usual standard therapies that I can use. When I am at the end there, then I have the chance to offer patients new innovative therapeutic approaches through studies.
That's a very, very broad question. But if we're really talking about this whole collection of different soft tissue sarcomas, how long does treatment typically take before people are sent home?
One thing that can definitely be said, it is not a short treatment that can be completed in a day. It is usually actually a treatment over several weeks or even months. That depends, as I said, a little on which modalities, which components, let's say, are all being used. If it's an operation followed by radiation therapy, then possibly followed by chemotherapy, then such a process could naturally take months in some cases.
We make these films because we want to give patients the opportunity to inform themselves as well as possible and also to be able to participate in the entire decision-making process with the doctors. And if you had a wish, what should the patients know that would be important to you, especially in dialogue and discussion with patients? What would that be?
Very clear statement. Soft tissue sarcomas are rare tumors, malignant tumors that should be handled by experts.
Wonderful that you are available to us today as an expert. So that was really an important observation on the topic of experts. So thank you very much that we had you, Professor Kasper, as an expert here in front of the camera today. We also want to take a closer look at other soft tissue sarcomas. And I think it is really important for those affected, for the patients, to be able to listen to or watch their own specific illness again. What happened there? So, many thanks.
With pleasure.